is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everyone? Dr. Zach Baker here of Rehab to Perform, and I've got Christian Huckfeldt with me, one of our 2 sports residents that we have here in our second cohort of the R2P sports residency. Every month, they do a journal article review where they go into the theme of our residency, which in this month, it's the foot and ankle. They find an associated journal article on that theme, and then they go through the weeds, do all the dirty work with the research, and then summarize it for our clinical staff as part of our weekly in-service. So, Christian, good to have you on here again. Do you mind diving in? We'll just get right into it. What was the article you chose, and really just the reason behind choosing it?
Yeah, absolutely. Thanks for having me. So the article is called Beyond the Diagnosis, Using Patient Characteristics and Domains of Tendon Health to Identify Latent Subgroups of Achilles Tendinopathy. And this is actually from the Delaware Tendon Group, this article. The reason I chose it is because I've had a few on my caseload pop up with Achilles tendinopathy in the past couple months or so, and they've ranged from younger kids, like 18 or so, to like older adults, middle-aged individuals. They've kind of ranged from higher activity levels and lower activity levels. So I just this was a good article that had a pretty good synopsis of, at least tried to classify them into different groups. So I thought it would be kind of beneficial for my clinical treatment.
Tendinopathy can be a frustrating thing, obviously for the patient, but also for the clinician to treat. And when you get to Achilles tendinopathy, I find that's one that can be even more challenging because even if you are doing your due diligence of modifying activity and trying to find ways to keep them active or keep them doing their daily routine and minimize the amount of stress on the Achilles, they're still walking. They're still putting weight on their legs. I think, when we talk about lower extremity tendinopathy, it may go through just even more wear and tear with your ADLs that can complicate the ability to allow that area to rest, allow it to recover. And sometimes it can be harder to find workarounds to stay active compared to when you have your upper extremities. So I think oftentimes it's a little bit easier to protect an elbow or to favor an elbow or a shoulder than it may be for lower extremity. And I think that's a conversation I find myself having with patients often. Christian, talk to us a little bit just about the design of the study and really what they were hoping to achieve with it.
Yeah, absolutely. So really the goal of this article was to take individuals with Achilles tendinopathy and look at their clinical examinations and compare them and see if they could kind of identify a couple different subgroups of individuals with Achilles tendinopathy in order to kind of better classify their symptoms. So what they did is they took a number of, actually 145 individuals with Achilles tendinopathy and performed a clinical exam where they selected like 14 different variables that were the most important based on previous tendinopathy studies. They were kind of clinically meaningful, and they ran each individual through every kind of test or measure and then looked to see if they could classify them into different subgroups. So a couple of the domains of tendon health that they looked at were symptoms, which makes sense. They looked at self-report pain with hopping, and they also looked at the VISA-A scale, looked at lower extremity function, so heel rise test, counter movement jump, drop counter movement jump. They looked at some patient-related factors like their BMI, maybe their self-reported quality of life. They looked at psychosocial factors or psychological factors like pain catastrophizing scale and kinesiophobia scale. And then lastly, they looked at like tendon structural and mechanical properties, so like cross-sectional area, thickness, viscosity. So they did a really good job at kind of really emphasizing the biopsychosocial model with biological factors of the tendon, the individual's self-report of the psychology behind it, and then really kind of classifying it all together.
I think that's when I'm hearing you describe the design and how they're trying to classify all these different types of tendinopathy. To me, it really resonates of that sounds just like a very good initial evaluation. And it encompasses the subjective, the objective components, getting a very good detailed history as to how and when this started. And then from a functional standpoint, how limited are they? What areas are they struggling in, either from just a competency standpoint or a tolerance standpoint? And I'm assuming that ideally what we can take away from this article is if we're able to accurately classify the type of tendinopathy we're dealing with, that should help better frame up what our plan of care looks like and probably what's the easiest barrier of entry for this individual from a intervention standpoint. Is that accurate?
Yeah, exactly. I think the researchers on this group do a good job at highlighting the purpose of this study is really to identify, can we classify them into subgroups? Based on the way research needs to run, they would then need to run a secondary study. Do these different subgroups respond to different treatments better? But I think at least for this aspect of it, if we can at least classify them into subgroups, we may be able to infer that hopefully they would do better with certain individualized type treatments.
Perfect. Yeah. What did they actually find? So if you don't mind going into just the exact of what they were able to find, were they able to draw any conclusions? And then if you don't mind just kind of elaborating on what were some personal takeaways that you got from this article?
Yeah, absolutely. So they ran a number of statistics and found that the best fitting model found 3 different subgroups: activity dominant, psychosocial dominant, and structure dominant. So diving into each individual one a little bit deeper, the activity dominant was the most individuals, so that was 67 total. These individuals had the highest physical activity. They were the youngest in age. They had the best self-report of symptoms. They had the best self-report of quality of life. They had lower kinesiophobia, and they kind of had minimal performance impairments with the heel rise test and the drop counter movement jump. So these individuals are probably going to be the people that we've seen in the research before that do really, really well with like a good structured 12-week Achilles loading program in the clinic. They have a pretty manageable symptoms. They have pretty good quality of life. They are not nervous to start loading the area, and they tend to do well that we've seen in other research with just like a good structured loading program. The second group is a psychosocial dominant group. So this group had the greatest psychological response. So they had the most they scored the highest in the pain catastrophizing scale and the highest in the kinesiophobia scale. One part that I thought was pretty interesting is they actually had similar structural properties of the tendon when compared to the activity dominant group, but they had significantly worse functional tests, so the counter movement jump and the heel rise, and the VISA-A, which shows their self-report of like pain and function. So I thought it was really interesting that their tendons compared to the activity dominant group were pretty similar in structure, yet because they were likely more nervous to load based on their psychosocial components of it, the condition was worse.
So it's like a self-preservation strategy, essentially. They have the components and the pieces to carry out the task. They're just not demonstrating the ability to do so, either, as you alluded to, either fear avoidance, apprehension, as opposed to a lack of structural integrity to do that.
Exactly, and then I think that kind of creates a cycle where if they're nervous to start loading the tendon, then their physical abilities of that tendon, based on like the counter movement jump, heel rise test, some of those physical innate abilities of the tendon decrease over time because of lack of use, and then it's kind of that cycle from there.
It's interesting you mentioned that. It's almost like chicken or the egg. Like,
yep.
Is this something that they're demonstrating a decrease in capacity because they lack the requisite strength from the injury, or is this secondary in nature and becomes more of a time loss injury where because they're fearful of loading, they're now deconditioning to a point that was honestly worse than what potentially the actual injury itself may have been. I think that highlights really a lot of what our job is when we're finishing our evaluation, we're going into developing a plan of care. It's how can we find ways for individuals to find success early on with exercise? And success can be defined in a lot of different ways. Success may be hitting a certain number of repetitions with an activity. You're hitting a new PR from a performance standpoint. Success may be able to gain access into a position that they didn't think they were going to be able to. And sometimes that creates maybe the need for a little bit of trickery or misconception where you're putting them kind of secretly into positions, and then middle of the exercise they go, oh, wow, I didn't know I could do that. I would have never tried that on my own. What were some of the big, I'll let you finish on the results, and then just other big takeaways that you had from this?
Yeah, of course. So the last group, so the first one was activity dominant, second one was psychosocial dominant, and the third group, which was the least amount of individuals, was the structure dominant. So this group had the greatest degree of tendon alteration in the mechanical properties. This group tended to be the oldest and was predominantly obese as a group. I thought the interesting part was a third of individuals could not do one single heel rise in this group. So there's pretty significant structural and then pretty significant like biological factors that are going on with these tendons. And this group, the authors hypothesized that there's probably some other systemic conditions going on just based on the demographics of those group. So in terms of the clinical relevance and the conclusions, I think it's important to note just again, these can't 100% specifically inform treatment recommendations based on the type of article, but it does help to put patients into different categories, which we as a clinician may be able to at least kind of hopefully infer what type of activity they would do better on. So kind of like I said, I think that activity dominant group is the group that probably just needs a good periodized Achilles tendon loading program, see where they are, see how much load they're currently getting, regress if you need, and then slowly, gradually build the tolerance over time. And we know tendons respond really, really well to exercise. I think that psychosocial group, just like you said, probably needs a lot of those similar things, but with more emphasis on kind of expectancy violation, kind of as you hinted at earlier, really seeing if you can get them into positions that they may not have been the most comfortable initially. So it probably needs more conversations early on and really kind of more attention at the psychological level. And that structure-dominant group, I mean, I think overall the Achilles tendon definitely needs to be loaded to hopefully show some improvement. But I think if we are just loading their Achilles tendon with heel rises, I think we're missing the boat with that group. With that group, just with the demographics, I think really just providing them exercise that may be trying to just meet physical activity guidelines, trying to just get them more active and create good exercise and activity habits over time. And then with that, hopefully down the road, will you be able to load the Achilles tendon a little bit more? Yeah, hopefully. But I think if you're just really laser focused in on the Achilles in that group, I think you're kind of missing the ball.
I think that was beautifully said. And going right off of that last group, sometimes the Achilles issues they're dealing with is just a symptom of a larger problem going on. And I think you mentioned you may be very limited as to what you can even accomplish by just directly loading the Achilles. And in reality, there's probably some bigger problems or just bigger behavioral changes that you can address. They're going to drastically improve their quality of life more so than being able to do a single heel raise. I think the other thing that you had mentioned, you really just laid out what does a universal plan of care look like in regards to we need to give them the permission to move and we need to put them in positions for success, that they're going to be safe in, that they're going to do well in, and that way you just gradually make them more complex, more involved, back to the point where they're doing what they want to do and what they love doing. We need to make sure that we're actually progressively strengthening them so that we're making that area of interest, the Achilles, the gastrocsoleus complex, intrinsic foot, and just the ability to have a stiff foot, stiff and compliant foot and ankle complex. We're doing things to protect that area and make that a little bit more resilient and a little bit more robust. But then we're also thinking big picture. And how do we just get these people moving again and develop a really general fitness and conditioning program? All of those pieces are going to be present with any Achilles patient that you encounter. How much you emphasize each piece, the order of which you go into that, or what you focus on in a treatment session versus what you're providing for educational components at home, that may be the largest variance between an individual that falls into one of these potential categories of classification. I think we've used the analogy before that the recipe for success for everyone, it has the same ingredients, just how much of each ingredient you put in and when you add that ingredient in may vary from person to person. So, Christian, I appreciate you taking the time for this. I enjoyed that article. I think it's always great to reflect back on really the evaluation process, how we are categorizing, how we are classifying people, potentially the terminology or just the influencing factors that may be at play, and then obviously use your own clinical judgment and just other resources you have within the literature to then figure out, based off what we are now able to quantify and qualify, is there a best standard of care or plan of attack to go after with this individual? So, Christian, appreciate you having you on.
Yeah, absolutely. Thanks for the opportunity.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.